gathered near. The doctor's in the house, so lend him your ear. The things he can say might even make your day. He might even help your pain go away. The doctor is in the house. The doctor is in the house. Let the doctor know what's bothering you. I'm sure he can tell you just what to do. The doctor is in the house. Doctor is in the house. Let the doctor know what's bothering you. The doctor is in the house. If you have a pain, call the doctor. If you have a sprain, call the doctor. Let the doctor know what you're going through. Let him tell you what's good for you, because the doctor is in the house. The doctor is in the house. Call the doctor. Call the doctor. Call the doctor. Call the doctor. Someone was having that.
Oh, yeah, Uncle Fred, and Doctor is in the house. And this is Dr. Ron, host of Dr. Ron, Unfiltered, Uncensored. And what a show we have for you tonight, ladies and gentlemen. Two high-powered, blockbusting guests. And as I tell you every week, please practice an attitude of gratitude toward yourself and others, because when you are more aware and appreciative of the good things that either you or other people do, it's usually easier to accept the unfavorable things too. Ladies and gentlemen, this show has no sponsors. We are self-funding, so I have to read something to you to keep everybody happy. This program contains general medical information. The medical information heard on this program is not advice and should not be treated as such. The information is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. You should never delay seeking medical advice, disregard medical advice, or discontinue medical treatment because of information heard on this program. You are encouraged to confirm any information obtained for this program with other sources and review all information regarding any medical condition or treatment with your physician. That being said, ladies and gentlemen, I do have to apologize for last week's technical difficulty. The show never got off the ground, and Mr. Poliafico and Dr. Powers were left hanging with after they planned to be on the program. So it was a Blog Talk Radio technical glitch, and they did nothing about it, but that's the way it goes. So we have a blockbuster show tonight, and our first guest is Frank Poliafico. And I've known Frank for many, many, many years. I had started a group in Chester, Pennsylvania called the Emergency Medical Associates, and Frank was a nurse at that time. And, you know, Frank has gone on, started his own company as an entrepreneur with emergency training excellence. He has started up programs in New York and Miami. He graduated from nursing school in 1971, and I guess I'll say it before he does. He's probably one of the few nurses that wouldn't kiss me. But be that as it may, Frank, why don't you tell our audience about your great career and what you've done in the field of cardiopulmonary resuscitation?
Well, first of all, I have to say I'm the only nurse I know you never tried to kiss, but I won't go any further than that. Thank you for having me on, Dr. Ron. I appreciate the opportunity. My background is emergency nursing and emergency medical services. Served for 3 years as director of EMS for the city of New York, then Miami, then I started the company you mentioned. And for the last 20 years, I've been working on the issue of sudden cardiac arrest. Established and ran a foundation to help set up defibrillator programs. And for the past 10 years, have worked as the Federal Aviation Administration's manager of their cardiac arrest response program. So I've had a full spectrum of emergency care involvement for the past 50 years, starting with your tutelage and mentorship when I first was getting going. So when I hear things about CPR and resuscitation, my ears perk up. And I saw an email recently that this message has been circulating again about you can do CPR on yourself.
Yeah, Frank, let me put this in perspective for our audience.
Okay.
And you're absolutely right. I got an email from a dear friend of this show, Dr. Will Wong, and he said, "What do you think of this email?" And it is exactly what Frank started to say: how to survive a heart attack when alone. And the email says, since many people are alone when they suffer a heart attack without help, the person whose heart is beating improperly or who begins to feel faint has only about 10 seconds left before losing consciousness. And it goes on, and that you should take a deep breath and cough and what have you. And I read this and I said, I know the person that's an expert in this. And before I just blindly forward it, let me call Frank Poliafico. And go ahead, Frank. That's where you came in.
Well, it has made the rounds of the internet for the past 15 years, and it is totally bogus. It has been debunked many, many times over. It is actually dangerous. First of all, cardiac arrest and a heart attack are two different events. A heart attack can lead to cardiac arrest, but we now know that more than half of the cardiac arrest that occurred did not start with a heart attack, with damaged heart muscle. For sudden cardiac arrest, the first time somebody knows they're in trouble, they're on the floor, unconscious. So there is no time. If they're having a heart attack, the medical term myocardial infarction, where the blood vessel is blocked and there's damaged heart muscle, the worst thing to do while you're still conscious is to exert yourself at all. So coughing during that episode is dangerous to the heart. It could cause cardiac arrest, as well as more damage to the heart. Cardiac arrest in and of itself, there's nothing you can do for yourself, absolutely nothing. The key there is to have people around you, as well as yourself, be trained to start CPR and get 911 on the way, and if at all possible, to use an AED, an automated external defibrillator, which is dramatically reducing the numbers of premature cardiac arrest deaths. But the choking, coughing issue, it just doesn't make sense. It sounds interesting, and a lot of times when things are interesting, people pick up some half-truths and start talking about it as though it was a reality. It is absolutely dangerous, and it doesn't work.
So if you have a sudden cardiac arrest, what does that mean to you?
A sudden cardiac arrest is an electrical malfunction in the heart, where the heart's mechanism that causes the heart to beat, to squeeze and relax, that mechanism gets to the point where it can't function, and the heart goes into a chaotic rhythm where it's like vibrating instead of squeezing. Instead of pumping, it's electrical anarchy. It's totally out of control. The only thing that's going to help that is defibrillation. We've known that since the 50s. We tried to get it to the streets in the 70s by instituting mobile intensive care units and paramedic programs. But as good as they are, they can't get there fast enough. You have to defibrillate within that first 5 minutes to really make a difference, ideally 3 to 5 minutes. So we have to correct the electrical problem. In the interim, CPR is a holding pattern. It temporarily sends oxygen to the brain until we can defibrillate. CPR was never intended to work by itself, despite the TV images on old shows like Baywatch and some of the other medical shows. You don't do CPR, they wake up and say, thanks, I needed that. I know you've done more than me, but I've been involved in about 300 cardiac arrest situations. Never once saw anybody wake up and say, thanks, doc, I needed that. They don't do that. If we can defibrillate them, there's a good chance that they're going to continue a normal, healthy, productive life. The vast majority of sudden cardiac arrest victims, by the way, are in their 30s, 40s, and 50s. So we're not talking about old-timers like me and you who have sudden cardiac arrest. But that means people have to be ready, and that's really the key, is to get people ready. And telling the victim they can get ready by themselves just doesn't make any sense at all.
And a sudden cardiac arrest, by definition, the person experiencing it will probably be on the ground and maybe somewhat unconscious. Is that right?
Absolutely unconscious. In fact, it's real easy to tell if they're in cardiac arrest. They've collapsed, there's no breathing, and there's no response. Really easy to tell. You see somebody collapse, don't think they're in cardiac arrest while they're talking to you. They've collapsed. They clearly are not responsive when you shake them and yell at them. And when you check, they're not breathing. You know, the old days you had to check for a pulse. Don't have to worry about that. If they're not breathing, they don't have a heartbeat. So we start CPR immediately and call for 911, get EMS on the way. If an AED is available, use that defibrillator, and then continue CPR until EMS shows up. That's the only thing that can make a difference, and it's making a dramatic difference. When AEDs are in place, for example, in flight, the airlines must carry them. Prior to that ruling in 2000, there was no survivors of cardiac arrest if it happened in flight. Today, there's 50% of cardiac arrest survive. That's amazing because defibrillators are there. On the ground, we're seeing programs now with 70, 75% save rates, as opposed to 5 to 15% save rates without early defibrillation. So it really does make the difference, but it's a system. It takes people to be trained properly, comfortable enough to do it, to do CPR and use the AED. It takes quick response from EMS, and then getting them to the right hospital. Used to be the rescue captain in Jacksonville, Florida, used to have a famous quote when they started their medic program, is that often people think if they run to the ER, they'll be in the arms of Jesus, and 10 minutes later they are, because they went to the wrong hospital.
Right.
Well, that's improved dramatically with the advent of emergency medicine, which you helped to pioneer. But still, there are certain hospitals that are better at these cardiac problems than others, and we just need to know where those are and get to those right hospitals.
So CPR, when it was traditionally taught, was so many pumps plus so many breaths. Now that's all changed, hasn't it?
Well, the numbers keep changing, but the basics have never changed, and I reduced it to 3 steps. Know where to put your hands, know where to put your mouth, and don't switch them. If you pump on the face and blow on the chest, that's not going to help. Seriously, they've gone from 15 to 1 and 30 to 2, but those are approximations. What you're trying to do is create some blood flow and to squeeze rhythmically, generally to the beat of Staying Alive. I love that song. I played it today in a CPR course I taught for some FAA safety inspectors. It's keep that chest moving, switch off frequently so that you don't fatigue, and you will fatigue. It's a very strenuous activity. And if we do that, we make a difference. Now, when we do it as professionals, we're doing a lot of it. So we get good at it by doing a lot of cases. Average people are going to do 1 or 2 in their lifetime, if that. So the reality is that we have to make them comfortable. They have to become comfortable doing it. And the more we overtrain them and tell them things like you can break the ribs, you can fracture the xiphoid notch, and all these other what I call boogeyman stories, we scare people. We have to get people to be comfortable doing it. And finally, very important to this issue, is who are they going to be doing it on? Infrequent responders primarily respond to people they know. 90% of the time that someone who's not in our business who does CPR, they know the victim. So it's not like stopping at the mall or at the airport and jumping on some stranger. This is somebody they know and care about. So let's get people to the point of comfort. We need to totally revamp the way we do CPR training. We need to downplay this whole issue of certification. It's not required in any state of the union to be certified to do CPR. It's just not required. Some regulatory bodies require it. Some licensing bodies require it. But it's not required that somebody know to be certified in CPR to help. So we need to do a whole revamp of that whole CPR system because if not, we're going to continue to have the tremendously high rate of cardiac arrest deaths, when in fact we know with a good system in place, we can reduce that by 70, 75%.
All right, that's great information. And before we wrap it up, Frank, you've interviewed some people. Is there any particular interview, or how many have you done that have survived cardiac arrest? I have
personally interviewed about 250 victims of cardiac arrest who survived, primarily thanks to the use of a defibrillator, an AED, an automated defibrillator. The youngest was 11. The oldest was 70. The average age was probably in their 40s and 50s. And of course, they're very grateful to be alive. They're very thankful that the people on scene were able to help them. But often that person on scene was one of us, was an emergency care professional, a physician, a lawyer I met recently. He was playing basketball in the Poconos. He collapsed. On the court next to him was an ER doc on vacation, and an AED had just been donated to the school. So, I mean, and that's great, and I'm grateful for him. But luck is not a strategy for success. We really need to relook at the way we're preparing people for sudden cardiac arrest and get more of them prepared and get them comfortable enough to do it. But as you say, there are always emotional moments when I'm talking to survivors. I've had the great joy of talking to 3 people who I worked on and survived. And one of them was a beautiful 50-year-old woman who I met by doing CPR on her at the Philadelphia airport several years ago. And she's doing quite well. So it's a matter of preparation, of getting people comfortable, of realizing what's going on, and being ready to respond. I think public information, getting the word out there is vitally important. I'm grateful for this opportunity to use your show to help get that word out there about being properly prepared. But being improperly prepared is dangerous. And go back to the original question, forget about coughing CPR. It doesn't work. It doesn't make sense. It's dangerous.
Excellent presentation, Frank. I really appreciate that. And I guess I'm going to come clean. And one of the persons that we worked on at Crozier-Chester Medical Center gave me a bottle of Crown Royal every Christmas until he died because we brought him back. I never shared it with you, but I guess I'm getting old now, so my conscience is bothering me.
Well,
so
you
thank you.
You didn't share the Crown Royal either. Yeah, thank you.
So thank you for that presentation. I think it had to be said, and of course there's reason for why people think they might be having cardiac arrest. It could be a tachycardia, it could be ventricular extrasystoles, whatever. But if you're having a true cardiac arrest, you're down and you're out, and you need help. All right, so Frank, if you wouldn't mind, could you stay on for a while, because our next guest is going to talk about something that might interest you a lot. And I told you before the show that Dr. Ron Unfiltered, Uncensored has changed the focus, and we want to make sure that we give our listeners enough information so they can be the CEO of their own bodies, so they can make the right decision for themselves and their family, or at least have a place to go to hear information they're not going to hear on the nightly news or from the mainstream media. And even though Dr. Powers, who I'm going to introduce shortly, has nothing to do with this, but medical error, ladies and gentlemen, is the 3rd leading cause of death in the United States. I mean, that's irrefutable. And it's not reported, okay? Cancer and heart disease are, and they get all the money. And I'm going to tell you something else. There have been no deaths from vitamins in 2011. There were 3 deaths from vitamins in 2004. 106,000 deaths every year from pharmaceutical drugs properly prescribed. There are between 76,000 and 137,000 deaths from pharmaceutical drugs every year in hospitalized patients. So who are the quacks in this whole scenario? I'm not going to go into more about that because we did a program on that a month ago. But I think it is apropos about what we're going to be talking about tonight, about the licensing of nurse practitioners. And we'll have Dr. Powers talk about that. But family physicians, ladies and gentlemen, have a graduate level of education of 4 years. They have a 3-year residency and fellowship training. And their total patient care hours through training can add up to 10,000 to 12,000 hours. Now, contrast that with graduate level education of a nurse practitioner of 2 to 4 years, no residency, and total patient care hours through training 500 to 700. So if doctors are the 3rd leading cause of death, what do you think will happen if the nurse practitioners do not have to work under doctors' supervision? And to discuss that, we're going to have Dr. Powers. Dr. Powers is the president of the Pennsylvania Medical Society. She earned her medical degree in Albany Medical College through a combined biomedical program. She's professionally held positions at Emory University School of Medicine and Emory Healthcare in Georgia, where she was the Teacher of the Year for anesthesiology residents, as well as the Director of Liver Transplant Anesthesiology. She has worked for the University of Pittsburgh Medical Center on the liver transplant team and the University of Pittsburgh School of Medicine. Also in Pittsburgh, she worked for Allegheny General Hospital, directing anesthesia research and teaching. While working within the scientific community, Dr. Powers conducted research to develop several pharmaceuticals. Dr. Powers is board certified in anesthesiology and works at Penn Highlights Hospital system. She also provides anesthesia services for rural independent physician-owned surgery centers. With that, I'd like to introduce Dr. Powers. Dr. Powers, how are you?
I'm good, thank you. How are you doing this evening?
We're doing a lot better than last week, aren't we? We were actually on the air.
Yeah, we are. Yeah, that's right.
And
right.
We're not wasting your time or Frank's time. I just as an aside, there was a Peter Safar at University of Pittsburgh, and I trained with him, and
Yeah.
I think he wrote the foreword to your book, didn't he, Frank?
Yes, he did.
Actually, he was a professor emeritus of anesthesia when I was doing my training, and he actually taught me some of the intraoperative cases. I worked on some cases in the OR with him, and he really shaped the department, and we also credited him at the time with kind of inventing CPR, at least moving it very far down the road. Yeah, he was amazing.
Yeah, he was the inventor, and he was a unbelievably brilliant man and a great gift to the world.
Yeah, and he was an incredible instructor. I mean, I remember so many pearls of wisdom that he passed on to us as residents. He was wonderful.
Yeah, I remember getting on Allegheny Airlines from Philadelphia to go up to study with him.
Yeah, he was amazing.
Many years ago. Well, Dr. Powers, can you just enlighten us about this? What's happening in Pennsylvania with the bills being introduced into the Congress there about nurse practitioners and how they want to be be able to practice on their own without any supervision. Could you just let our audience give us an idea what's happening?
Well, it's happening in Pennsylvania as well as other states in the nation, but in Pennsylvania in particular, we have a situation where nurse practitioners are allowed to practice, diagnose, prescribe, but there is a requirement that there exist a collaborative agreement with a physician so that the nurse practitioner has available to the nurse practitioner, a doctor to consult with, to have available with patient care. And there is a push now coming from some members of the nurse practitioner community that they feel that collaborative agreement should not be required, and they're trying to get that requirement removed in our state.
And where are they now? I mean, they not only want to get rid of the collaborative agreement, but they would like to have private offices. Am I wrong or right?
Yeah, I think they're pushing to practice in a sense as physicians, to have the same authority as a physician would have, with, as you said, far less training. And the Medical Society of Pennsylvania, our members have been pretty consistent over the years. They've never wavered from this. The membership of the Pennsylvania Medical Society feels that this would not be in the best interest of patient care if those policies of requiring a collaborative agreement were to be removed. And we have our reasoning, of course.
So, and it's happening in other states as well.
Yeah, there are states where there's throughout the country of what different states have done. Slightly more than half still require some kind of collaboration or involvement of a physician with a nurse practitioner, but a fairly large number are also in the stages of removing those requirements or doing away with them altogether.
Well, what is the Pennsylvania Medical Society doing? What can the listeners in Pennsylvania do to help the Pennsylvania Medical Society in its cause? So the nurse practitioners must have supervision by a licensed physician. Right.
Well, we're working mainly to educate legislators and the public about why we feel that this is not a good idea for patient care. I mean, as you mentioned in the introduction, there's a huge difference in the amount of training that between a physician and a nurse practitioner. On average, physicians have somewhere between 12 and 15,000 hours of clinical training taking care of patients where that physician in training is supervised. So a physician going through the training process is overseen for 12 to 15,000 hours as they take care of patients by other physicians and senior doctors. A nurse practitioner goes through about 700 to 800 hours. In addition, the training given to a physician is far more in depth. The physicians spend a lot more years in school, and the coursework that they take goes far more into depth about disease processes, the theories of what is going on, the actual molecular, biochemical, physical processes that are felt to underlie the disease, the theories behind the treatments, the parameters under which the treatments are and are not appropriate, the other issues that need to be considered for a patient when you're trying to evaluate them. And that level of training and understanding just doesn't happen with the nurse practitioners. That does not mean that the nurse practitioners are not valuable parts of the care team. The policy is not that nurse practitioners should not be involved in patient care. It's that they don't have the training, the expertise, and the depth of understanding to take care of patients without some kind of collaboration with a physician. Because patients don't walk in with a sign that says, my problem is simple, you don't have to know a whole lot to keep me safe. They walk in with a problem, and they rely on the expertise of the healthcare professional that they are seeing to understand when the problem is simple, when it is slightly more complicated, or when it's truly life-threatening, and to have that practitioner know how you diagnose, how you intervene, and how you differentiate. That takes years of experience, years of training, years of supervision, and a fairly complex level of understanding of what is causing the disease. And we just think it's not fair to patients to remove that and say, any particular patient doesn't deserve that level of expertise when they go see a doctor or a healthcare professional. And so our position is valuable member of the healthcare team, but in the context of they can't that they have someone else available for a complex patient, a confusing picture, something that is out of the ordinary or that needs additional understanding to make the right diagnosis and render the right care.
So, do you think is this getting enough publicity in Pennsylvania that the average person knows about what's going on?
I think we could do a better job of getting the word out. We're certainly trying to become more involved and become better communicators. I think physicians sometimes have the feeling that something is so obvious we shouldn't need to say it. And unfortunately, I think what all of us have learned is that just because something seems obvious to us, if we don't take the time to educate, to interact, and to explain, other people have busy lives, they've got other interests. Most people don't think about their health till they're sick. And so they're living very active, busy lives, maybe pursuing a degree, maybe, playing sports, involved in raising a family, starting a career. They're not thinking about who they're going to see if they get sick. And we do have to do a better job as physicians in trying to educate people and get the word out. And we are trying to work in that direction. We're definitely moving in the direction of doing a better job of communicating. Yeah, but
there's a journal out called Policy, Politics, and Nursing Practice, and they published recently an article highlighting the potential crisis in nurse practitioner preparation in the United States. And from that article, it said every day patients in the United States are being denied access to physician-led care and are often directed to a nursing practitioner, as they are told they can do everything the physician can without the patient actually knowing what's going on.
Yeah, we had a law that was passed here several years ago that said that a healthcare practitioner has to have their degree prominently displayed. So one of the things that was happening is people didn't know if they were what level of training the person taking care of them had, and whether intentionally or unintentionally, there were practitioners who weren't physicians who were kind of obscuring the fact that they weren't doctors. And so patients were seeing people, they would come, they would say, my doctor said this or my doctor said that, and you would reach out to the person and find out it actually wasn't a physician they were seeing. And I have a kind of a pet peeve with the talk about non-physicians or nurse practitioners or what we call mid-levels being said that they're going to be a solution for rural access problems, because right now I have a very rural practice. I spent many years working in urban centers and at large academic institutions, but right now my practice is primarily rural in what you could call physician underserved areas. And I actually have come to the conclusion based on that, the last place you should send an unsupervised practitioner is in an area without many doctors. if you're going to have a problem missed or misdiagnosed or something maybe not properly handled, you don't want it to be somewhere where there are not enough physicians for a physician to catch it. And I have kind of pushed back sometimes and said, don't tell me that because a patient is rural, they deserve a different standard of care. If anything, I think we should be more stringent in rural areas because it's more important when you don't have a lot of doctors that there is a physician available for complex patients or care that seems difficult. And there have been some studies that have come out that have actually shown that now there's not a lot of studies, but there have been some that are starting to document some of the problems with this difference in training being ignored. There was a study that came out of the Mayo Clinic, and what they did was they looked at referrals of patients to what are called tertiary care centers, which are hospitals with very high levels of expertise and a very broad depth of specialties available. So a patient may have a problem, and they're eventually referred to a tertiary care hospital. And what they did was they looked at referrals coming from nurse practitioners and referrals coming from physicians, and they had a panel that evaluated the referrals, whether they were appropriate, whether the patient had been treated properly prior to the referral, whether they had been diagnosed properly, had been having the proper tests and the proper therapy. And they blinded the reviewers to whether it was a nurse practitioner or a physician who had been taking care of the patient prior to the referral. And it was a pretty dramatic difference in the conclusions of the panel, that basically it was dramatic that the patients who had been seen and followed by physicians had much more appropriate care, evaluation, therapy, and referrals. In other words, it was appropriate that they were being referred. And that's not to say that nurse practitioners, again, aren't a valuable part of the team. It's just they're doing something beyond their level of training, and it's not fair to the patient. So that kind of also throws a monkey wrench into this whole idea of, well, it'll be cheaper. We can get care and we can lower the cost. If we're doing inappropriate care or unnecessary testing or missing appropriate tests and delaying treatment, in the long run, you're not only probably going to spend more money, you're going to be harming patients as well as spending more money. So we have to use common sense, knowledge, and the science of what's really going on in medical care to make appropriate policy decisions.
And that's the last chapter in my book that I'm writing, How to Die Young at an Old Age. It's called Common Sense. And
right.
That's so important. It really is so important. And I found, even though I'm not actively practicing now, I am in touch with a lot of physicians, that the nurse practitioners order a lot of testing.
Right.
Just because they don't know, they can't zero in, and they don't do a good physical examination. So
they
just
diagnose.
Right, exactly.
Yeah, well,
exactly.
You know, if you spend 12,000 hours taking care of patients, being supervised by an older physician, more experienced physician, you learn clinical signs, you learn the questions, you learn the diseases, you learn the processes. A well-trained doctor can often make a diagnosis with no testing, whereas somebody who's less well-trained or less experienced has to rely on all sorts of tests because they don't have the clinical understanding to say this is what the disease probably is. And I think one of the mistakes we are making in American medicine is not giving physicians enough time to practice to the level of their training. I mean, sometimes if you give a doctor a little more time to do a little more questioning and physical exam, you'd save a lot of testing. I think you would agree with that.
Yes.
You know, it's rushing these patients through, 8 minutes, 10 minutes, and then you say, why do you have to do so many tests? Because you have an expert who didn't get the 20 extra minutes that they needed to make the diagnosis. And then if you try to do the same thing with people who don't have the same level of training, all you're doing is running a testing mill.
I told the students that used to come to my office that the majority of time, a good history,
right.
when it's done properly, you sort of know exactly what you're dealing with before you put your hands on the patient.
Exactly.
And at my 50th reunion, I told the class that the paradigm today seems to be, well, all the tests are normal. Let's go examine the patient.
Yeah.
And,
there's there's a fascinating story of that was written in one of our journals, the Journal of the American Medical Association, where a woman was complaining of chest pain and had a total cardiac workup that was negative. And finally, at the bedside one day, somebody pulled the gown down and saw the rash of herpes of varicella.
Zoster, shingles.
Yeah, zoster. She had shingles. And so the whole time she was complaining of chest pain, nobody had looked at her chest. She had an entire cardiac workup. I would say that's a problem. And that showed up in the journal because the person writing it was saying we need to really go back to the time where the doctor took the time to talk to the patient, examine the patient, and come to a conclusion, and then only order tests if you needed a test to decide between disease A and disease B.
So, Dr. Powers, what website would you recommend our listeners to go to in Pennsylvania to get a little bit more education?
Actually, the Pennsylvania Medical Society is a good website, and we do have information on this. And our website is pamedsoc.org. So pamedsoc.org. And there are links there that discuss our positions, what our policies are, and there's some information. It's aimed toward both physicians and the public.
And I came across an organization in preparation for this show called Physicians for Patient Protection.
Yeah.
And they're trying to show transparency regarding healthcare practitioners, and they are fighting to uphold the highest standards of patient care. So our listeners can look up that organization, Physicians for Patient Protection.
Well, that's national. I think
yes.
That's a national. Yeah, that's
it
national.
Is.
And they're actually excellent. They're doing a lot of very good work.
And then go to the Pennsylvania Medical Society website, which is pamedsoc.org, and just educate yourself on this. And if I was in Pennsylvania, I would be telling you to go, call your local congressman, because politics all starts from the bottom up. So call your local guy or local woman and complain about it. You want to be treated by a doctor, you're going to be paying the same price or maybe more if the diagnosis is missed. So
right. Well, and the thing is, again, it isn't that nurse practitioners are not a valuable part of the care team. Nobody is saying, or I'm not aware of anybody who's saying they shouldn't be part of the healthcare delivery system. What our position is every patient should have available to them somebody with the highest level of training possible, because you never know what patient is going to be the one that needs that highest level of training. As I said, patients don't walk in with a sign that says my problem is simple. You don't need to know that extra 10,000 hours to diagnose me. And I'm sure you've seen this. You've seen someone who walks in, it looks like a simple problem, and all of a sudden, they're being told you've got to get to the nearest hospital. There's things that present simply but are actually very serious.
Well, I just had an episode with a relative who had a steak in his esophagus, and little did the person know that was doing the gastroscopy, he had perforated his esophagus.
Wow. And
he made it worse, and thank God for Thomas Jefferson University Hospital. They saved his life.
Yeah.
But Frank, you brought up something interesting prior to the show about malpractice and lawsuits of nurse practitioners. Do you want to ask Dr. Powers? Frank's still there. Frank was saying that nurse. Are you still there?
He was muted.
Yeah, I'm still here. I'm sorry. I'm not practicing anymore, so I make that clear, and I'm sort of retired. But my information in talking to some of the nurse practitioners I know is that lawsuits against the nurse practitioners are far less, even though most of them have their own insurance, than against physicians. Also, I want to preface what I say by I agree with Dr. Powers. As a nurse for 52 years, I've always believed the physician's captain of the ship. And I think that, many of the issues you're discussing here, we went through when we were initiating paramedic programs. And the ultimate solution, which was a battle, was that we would have medical control of paramedics. There were those who subscribed to independent practice paramedics, and of course, I always thought that was a disaster. And I agree that we need physician leadership. I think there needs to be a real good established standard of care and a table of organization to maintain that standard of care so that people aren't trying to do things that are beyond their ability. And the issues of lawsuits is going to be one of that supervision of the standard of care. Obviously, none of us are perfect, but we have to make sure that we have that established standard and that it's not just being developed by the academicians. There's clearly a big push to train more nurses as nurse practitioners, and that a lot of that push is coming from the academic institutions. So I think there has to be a well-rounded look at this whole issue. And I've seen nurse practitioners and I've seen physicians. And what I like in nurse practitioners is when they know when to punt. When they know they can handle it, they do. When they can't, they need to know how to punt. And I think that's something that has to be well established in that standard of care.
And I have to say, along the lines of punting, I have had conversations with individuals, nurse practitioners. They don't want to do away with the collaborative agreement. There are people who will say, I want to have the physician available. I don't want to feel pressured to work without a physician available to me. So I don't know if anyone has actually looked into the percentage of nurse practitioners that actually are more comfortable with a collaborative agreement and would prefer not to have that change. But certainly I have had discussions with individuals who have said, I'm not one of the people pushing for this. I would rather be in an environment where the physician is available and kind of I'm required to have a physician there.
Dr. Powers, there's a couple people here who may have a question. On line 286, did you have a question for Dr. Powers or Poliafico?
Basically, what is the main difference between a PA and physician assistant?
I think
Dr. Powers.
Oh, yeah. I'm not an expert, so you're going to get my understanding. And my understanding is that a nurse practitioner gets an undergraduate degree that usually has a basis in nursing. So they have a bachelor's degree in nursing or a diploma or an associate's degree in nursing. And then they go beyond that and take an additional degree program that gives them the nurse practitioner degree. And they can get either a master's level, and there are programs that are called doctorates. Some of those are done online. A physician's assistant, my understanding is they can go through in kind of any kind of background in with an undergraduate college degree, and then they take I think a structured, I believe it's 2-year course, it may be more, that is more broadly based sort of in medicine and physiology. And their training is more along the lines of working under physicians or with physicians. So I think one is from more of a nursing background. The other is more of a I don't want to use the word medical. Not that nursing isn't medical, but it's more of a sort of a light version of a medical degree.
Thank you. I appreciate that.
Yeah.
Yeah, I think transparency, that's a word that you had mentioned. I think that's really important. We need to know the education and the background of the person treating the client, the patient now. So I think that's going to be an important part of solving the problem.
Well, yeah, as I said, in Pennsylvania, it's required. You need to have something that identifies you and what your degree is. So it needs to say either physician or physician's assistant or certified registered, nurse practitioner, and so that the patient is aware of who they're interacting with, and it's at all levels. I mean, registered nurses have to say registered nurses, LPNs. Those titles have to be on the name tag or in some place that identified so that the patient can see who it is they're interacting with. I mean, the healthcare system now has become very complicated. We have many people at many different levels that are very important in the healthcare delivery system. And patients can get confused, you know. It used to be you kind of could tell by the white coat or the scrubs or whatever, but patients would get very confused now. You know, we have people coming in for dietary assistance. The pharmacists come around. Of course, you have all the different levels of nursing. You have the different levels of medical training. And I think it can get very hard for a patient, particularly someone having complex or long-term issues that they're getting care for. And it's important that they at least have an understanding of who it is that they're interacting with and who it is that's giving them advice.
Well, I think it's an interesting discussion, and I think one that has to be further identified, and somehow the patient has to know who's treating them, who has the stethoscope around their neck, what their training is. Did they get their degree online? I mean, that is scary.
I think I think more than half of the NP schools now are done online.
That's really scary before you touch a patient. I know in Spain, after 2 years of college, you go right to medical school, and they never see a patient, and they get a degree.
Yeah.
And that's why a lot of the Europeans would always come to America for treatment. Same in my home country of Italy. Say 2 years of college, you can go right to medical school. Doesn't mean they're not good, but they don't have the level of expertise as the American trained doctor. So, Dr. Powers, if we had to wrap it up, so what would you say to our listeners? What advice should they do? They should look at the website? What do you advise them to do so we can help to get some clarity for nurse practitioners and whether they should be licensed?
Well, I think in their own care, when they go to see a practice or see a practitioner, they should ask, you know, who they're seeing. They should establish a relationship with either the group that's taking care of them or the individual physician, and make sure that they feel comfortable with who it is that is giving them their care. I think they should also be willing to advocate for themselves. I know people who tell me, I wanted to see the doctor, but they told me I couldn't. I think the patient should feel comfortable speaking up and saying, no, I would like to see the physician, or no, I feel comfortable seeing, your nurse practitioner, but the patient should be willing to advocate for themselves. And then in discussions with policymakers, they should make their wishes known as to what they feel is important for their care. And I think most people would say they want to have the highest level of training available when they need health care or when they need an intervention from the medical system. And then keep yourself informed, pay attention to what's going on, and dialogue with other individuals, share stories, that kind of stuff. It's important.
Very, very important. In fact, I think this information is so important. I'm going to run this program again Thursday night at 7 p.m. Just to get it out there so more of the listeners in the podcast arena. And we're on Spotify and iHeartRadio, Apple Podcasts. We're on TuneIn Radio. We're on Google Play. So we want to get more and more people to be knowledgeable about this, since the subtitle of our program is be the CEO of your own body and get educated about what you can do. So we will run this program again, and at some later date. I did reach out to Physicians for Patient Protection, so they're going to send somebody to be interviewed. So I think we'll just continue this type of discussion into the future, and then maybe in a little while I can get in touch with you, and we can see where we are maybe in a few months. That would be great, and thank you for all you're doing to continue the dialogue. It's an important one. Thank you. And I thank you for your time. So, Dr. Powers. That can go on, and she deserves it, but we're running out of time. So, Dr. Powers, thank you so very much, and God bless. Thank you. So, Frank, how did you feel about all of this?
Well, I agree with most of what the doctor said. I think that if we're talking about the delivery of medical care, we're talking about physician oversight. And there are a number of things that can be done by what are affectionately referred to as physician extenders. And a lot of people don't like that term because they feel it's demeaning. I think it's more accurate. But clearly there needs to be some established standards of care, and then within that standard, leadership and referral.
Right.
So I'm not opposed to what's being said. I've watched nurse practitioners in action, and I've admired what they do, both in the emergency room and in private practices. But there's no question that they are a valuable asset to the team, as Dr. Powers said. It's how they're being managed and who's leading that whole effort that really is ultimately going to make the difference.
Exactly. I think you summarized it beautifully. So, ladies and gentlemen, you listened in the beginning of the show to Mr. Frank Poliafico talk about some of the fallacies of CPR, and then we followed up with Dr. Powers, president of the Pennsylvania Medical Society, discussing nurse practitioners and their collaborative agreements. So we will follow up with this with future programs and with the organization called Physicians for Practice Protection that is pushing for transparency in the person that's treating you, so you know exactly who's treating you and what their education is. And next week, ladies and gentlemen, we really have to make up some time, so we will not have a single guest. I've asked Frank Poliafico, he's a wealth of knowledge. He's traveled the world. He's a state-of-the-art magician of all things. He is the expert on CPR, teaching CPR on oil rigs, airplanes, what have you, and being a brilliant nurse to start with. So I've asked him to come back, and he has some things he'd like to talk about. I want to just bring you up to date next week on some drug interactions. I want to talk to you about getting too many CAT scans. There's a group out there that has measured the radiation of CAT scans. Just like a group that measured mammograms, every 500 mammograms can result in one carcinoma. So you're not going to hear that from the surgeon, but I'll give you the documentation for that next week. So there's just so much going on that you're just not going to hear on the mainstream news, especially with drugs. And I told you in the beginning of September about Zantac and the cancer-causing ingredient in it. And now it's just making the headlines now. So I want to revisit acid reflux drugs because they have some devious side effects, ladies and gentlemen. And there are drugs that kill, sorry to say. So with that, we will look forward to talking to you about also coffee. And as you know, I feel that inflammation is the basis of most chronic diseases. And ladies and gentlemen, do you think your cells in your body can be renewed? And maybe we'll have time to talk about that also. So with that, I want to thank everybody for listening. Thank you, callers, for some of the questions I couldn't get to. So I appreciate your listening. And Frank, thank you so much. And I will catch up with you during the week. So thank you so much.
Look forward to it. Thank you for having me.
Hey, ladies and gentlemen, thank you for listening to Dr. Ron, Unfiltered, Uncensored, with Dr. Ron and Dr. Jerry. We are here each and every week to bring you medical news that you can use and medical news that you will not hear on the mainstream media. We hope you enjoy our podcast, and we hope to see you on the radio next week. Have a great one. Ciao.